Thank you very much, Willem, for the introduction. Ladies and gentlemen, good morning. First of all, I would like to thank the organization for inviting me. It's a great pleasure to talk to you today. I'm going to present and talk about the microcirculation and how to monitor the microcirculation. So maintenance of a normal cardiovascular function is a very complex process influenced by the autonomic central and peripheral nervous system. Paracrine, endocrine hormones influence this, the cardiovascular system itself, renal function, and especially in very premature neonates, this is a very challenging situation, as well as neonates with congenital malformations, such as congenital heart malformations. So if the cardiovascular function is abnormal, this is associated with the potential of severe morbidity and mortality. Therefore, it's very important that we monitor this. So the goal of hemodynamic monitoring is to detect inadequate tissue perfusion and oxygenation at a very early stage, preferably long before it becomes detrimental. And can we just have a quick show of hands? Who routinely monitors the parameters on this slide in their ICU? I'm surprised that I don't get 100%, so is everybody awake? Of course, this is what we measure routinely on a daily basis: heart rate, blood pressure, saturation, and of course they are easy to measure, but I'd like to tell you a little secret. These are all quite insensitive to give you information about tissue perfusion. So we like to recognize a situation where the circulation fails to meet the metabolic demands of the tissues in an early stage. In other words, we want to recognize shock in a very early stage. And this slide shows you very nicely the different forms of shock you all know, but it can be quite challenging to recognize the difference. And it shows you nicely that the difference is here, and that makes it clear that you will need different strategies to actually treat the shock. And this is what we're trying to get right: the balance between oxygen delivery and oxygen consumption. And Willem has already told us about this, but I think this is what we're trying to optimize in our patients with cardiovascular problems. So we can influence the oxygen consumption by the different measures we take. And on the delivery side, there are the three components that we just saw in the previous presentation. So oxygen carrying capacity that we can influence with, for example, blood transfusion, oxygen uptake in the lungs that we can monitor with our saturation. And we like to get an idea about cardiac output, which of course you know is influenced by all these factors, and we all try to influence them in our own ways to see if we can optimize the flow. So the most important thing, however, is missing on this slide, and that is the circulation at a microvascular level. The microcirculation plays a crucial role in the interaction between blood and tissue. And an optimal macrocirculation is a prerequisite, but no guarantee for adequate regional perfusion. The analysis of microvascular blood flow gives a unique perspective in disease process and gives you insight of pathophysiology. And there's no absolute threshold for blood pressure that defines adequate perfusion of the tissues. And that is not between different organs, but also between different patients, or even in the same patient at different time points. These thresholds can vary. And measuring the microcirculatory blood flow is a direct indicator of adequate oxygen and nutrient supplies to the cells. This is a very interesting paper. It's a review that gives you an overview of the different components of the circulation. So mainly macrocirculation here, and how what monitoring abilities we have nowadays. And again, this is what we want to this is what we want to focus on. And as you can see, the microcirculation is actually closest to the core business that we want to monitor. And I'm just going to repeat myself because I think this is critically important to take home today from this talk, is that despite normal systemic hemodynamics, regional tissue hypoxia can persist. And overall, routinely measured macrocirculatory parameters are very insensitive for tissue perfusion. So it's time that we expand our monitoring from the macrocirculation to the microcirculation. And over the last decades, there's new techniques that come into place that can visualize the microcirculation directly at the bedside. So this is the first technique, orthogonal polarization spectral imaging, a successor, and there's even a newer form coming onto the market recently. And it actually uses polarized light that's absorbed by hemoglobin, and therefore presenting hemoglobin as black in your field of vision. So this is an example, and maybe with the light it's not terribly clear, of the first technique, orthogonal polarization spectral imaging. And what you see here is a network of very small vessels. So basically you see the red blood cells presented as little black dots flowing through your field of view. And I'm just going to show you a few slides on how to look at these patients and the ways we actually analyze this type of images to give you an understanding of the parameters you will see further on in my presentation. So two parameters that are really important are convection, which is actually the transport of the oxygen over a longer distance, and diffusion, which is the journey of the oxygen molecule from your end capillary to the cells. And on this cartoon here, you can see nicely that when your capillary density decreases, so these vessels fall out, you see that has huge implications for your diffusion capacity. So therefore, I think capillary density is a very sensitive marker. This is an example of how you could look at this density. So basically you draw all the little capillaries that are perfused with red blood cells, and the computer can calculate the density. This is an analysis that looks at flow. So the microvascular flow index is a semi-quantitative scoring system, and basically you take 4 quadrants, and in every quadrant you identify small, medium and large vessels, and for every vessel type you give a score for the flow, and then you average it for the 4 quadrants. Another aspect that is very important is the heterogeneity. So especially in patients with sepsis, we have noticed that there can be a huge difference between some areas that are very well perfused or even hyperperfused compared to other areas where there's no flow at all. And that's where the heterogeneity index comes into place, and that actually gives you an idea of the heterogeneity in the images. This is a black slide. So let me show you a few examples. So most of the research that I've done in Rotterdam in the Sophia Children's Hospital. And this is one of the first studies we did where we looked into the buccal mucosa of children and neonates without any form of respiratory or cardiovascular support. So as normal as you can get it in a hospital, really. And what you see here is that children or neonates under 1 week of age have a higher functional capillary density than children at an older age. This is consistent with observations by Ursula Genzel. Ursula Genzel is in Germany, and she has done a lot of work in premature neonates. And in premature neonates, the site that is most examined is actually the skin of the arm, and this is the type of pictures you get. And again, the vessel density between day 1 and 5 of life was constant, and interestingly, and a nice overlap with my work, is that there was no difference between term and preterm babies. The red blood cell velocity increases between day 1 and 5, which correlates well with a decrease in hematocrit. And I think this is important to remember. So in the first month of life, in these preterm neonates, the functional capillary density decreased, and this correlated with a change in hemoglobin as well as an incubator temperature. And this is probably something to keep in mind to understand later slides I'll show you. So now let's look into disease and effective treatment. So this is a study, or actually 2 studies from Rotterdam again, where we looked at children, at neonates with severe respiratory failure. And we compared children in that situation who went on to receive ECMO treatment with children who did not require ECMO but had the same presentation. So on the first cartoon here, you see on this side patients who received ECMO treatment versus patients who were managed conservatively. These were mainly neonates with PPHN. And what you see is, in a way, the microcirculation was stabilized on the first day that ECMO was started, whilst with the same time interval, the conservatively managed patients had a decrease in their functional capillary density. And in this study, we actually looked at the microcirculation, excuse me, before and after ECMO treatment, and we compared this with neonates who did not receive ECMO. So for your reference, this is a normal functional capillary density, and these patients have a significantly reduced microvascular perfusion, and the children who were treated with ECMO, after they came off ECMO, had a significant increase in the functional capillary density, whilst the children who were managed conservatively had actually a decrease, or this was not significant, so their microcirculation did not change in the same time interval. And I think this is very interesting for neonatologists, because when I did neonatology, we were always very excited to use inhaled nitric oxide, because we all feel that's such a good treatment strategy for children with PPHN, because it doesn't affect the systemic vascular blood pressure as much as other vasodilators. So in this study, we actually found that it does affect the systemic circulation. So we observed the microcirculation in the buccal mucosa, and what we saw before inhaled nitric oxide, the functional capillary density was lower, and it actually increased, whilst there were no changes in microvascular or global systemic circulation. There was a recruitment of capillaries observed after the start of inhaled nitric oxide. This is a study that shows, again, in premature neonates, so in the arm, that a blood transfusion improves the capillary, or this is actually a total vessel density of the arm. Recently, they published a study that looked at the effect of the PDA closure. So the gray boxes are the neonates that received treatment for PDA, and the white boxes are patients who did not have a PDA. And as you remember from previous slides, the functional capillary density in normal, healthy, premature neonates actually decreases over time. And what you see here is that initially children with a PDA have a lower functional vascular density compared to children or neonates who don't have a PDA. And this difference actually disappears. So basically, relatively, the vessel density goes up. And the other interesting thing is that there was a difference between the right and the left arm, which there's no clear explanation for that as far as we know. Now I'll take you back again to term neonates and older children, and I'm going to talk a little bit about sepsis. So this is one of the studies I did in Rotterdam, showing that children who were admitted with severe septic shock had a significantly decreased functional capillary density compared to normal. And in subsequent days, this gradually improves. And we did look at these data a little bit closer, and what we noticed that there was a difference between survivors and non-survivors. As you can see here, in the survivors between day 1 and day 2, there was a significant increase in functional capillary density, whilst this was lacking in the non-survivors. And although this is a study in a small group of patients, we found that this had actually a significant prognostic value for outcome, which is for mortality. This is an example of an image of a newer technique, so the SDF technique. And you see very nicely that the blood is flowing. There's a nice network, and you can see here the venous sides. And it looks like there's small white dots, which are actually the things you don't see, because you do see the hemoglobin, which are the black dots flowing through your field of view. And you don't need to be an expert to pick up the difference between the slide I just showed you and this slide. So this is an image of a patient with sepsis, and it's quite easy to understand the difference. So sepsis is a very complex process. So there's the initial infection, and there are many factors that actually influence the pathophysiology and the outcome. So of course there's the background of comorbidities and genetic makeup, the time of presentation, as well as the timing of your treatments. There's many vascular processes that go on that influence cellular distress, autoregulation, and have impact on organ function. But most central here is a microvascular dysfunction that we just saw on the video of the septic patients. In Liverpool, they have examined children with meningococcal sepsis, and this is consistent with a huge bulk of work that's been in adults as well as our study in Rotterdam, where they found microvascular disturbances early in sepsis, which were actually improving consistent with clinical outcome. This is one of the key studies in adults by Sacker, who examined the microcirculation for 7 subsequent days in patients who presented with severe septic shock. The dark grey boxes here are the patients who survived, and the other boxes here are the patients who did not survive. And again, it's quite striking, the difference, that there's no improvement of the microcirculation in patients who went on to die. And similar to what we found is that the lack of improvement of the microvasculatory values is a strong predictive value for outcome. Then we go back to what we know in premature neonates. So this is a study that has observed the microcirculation in the arm of preterm neonates. And this was a prospective study where they studied the microcirculation on subsequent days, and they found that before the children developed sepsis, there was actually a difference in their microcirculatory parameters. And this is a more recent study that looked at the effect of hypotension on the microcirculation, or maybe the other way around. This is an observational study where, again, in premature babies, they measured the microcirculation on subsequent days after birth, or actually shorter time intervals here, and they compared the children who developed hypotension with the children who did not develop hypotension. So the grey boxes here are the children who developed hypotension and received treatment with fluid resuscitation and inotropes, compared to the children who did not develop hypotension. And you see that there's an initial significant difference between the two. But I do have to say that there was a difference in temperature as well as a slight difference in age, which could have influenced this outcome. So now let's look at treatment strategies and how they influence the microcirculation. So we all use fluid resuscitation to improve our circulation. And there are good aspects of fluid resuscitation. As we've heard, we can improve our preload and therefore stroke volume, and that will have a positive effect on tissue oxygenation. Also, it will change our viscosity, so therefore a better rheology and a better tissue perfusion. But there's a lot of bad things, especially if you give too much. So venous congestion, edema, and other processes that are actually bad for the microcirculatory perfusion. This is an adult study showing that increase of preloads in volume-dependent shock actually improves your microcirculation. And I think this is a very striking study, which is very relevant. So again, this is an adult study where they looked at the development of the microcirculation and the development of organ dysfunction. So basically, they started early goal-directed therapy in patients with sepsis, and they did a microcirculatory assessment in the first 3 hours, and a subsequent measurement in the next 3 to 6 hours. And they looked at the development between these two, and they looked at the SOFA score between hour 0 and 24 hours later, and a SOFA score is a score for organ dysfunction. And what they found is if the microcirculation improved, the SOFA score improved, whilst if the microcirculation, so very early on in the presentation, decreased, there was a worsening of the SOFA score 24 hours later. So this tells us that it is critical to resuscitate your microcirculation early on in your process, and that has implications for the rest of your treatment and outcome. They've looked at different solutions used for fluid resuscitation. So they compared human albumin solution with saline. This is actually starch with saline. And they aimed for the same effect on mean arterial blood pressure. And it was noticed that a lot more saline was needed compared to HES that was given. And HES actually significantly improved the microcirculatory flow index in a better way than saline did. And also the vessel density improved more so in patients that received HES. Dobutamine, a drug that's used in all age groups, it was shown that there was a recruitment of the microcirculation with dobutamine. And of course you will say, like, yeah, that's not very surprising, because that is probably based on the fact that cardiac output improved. But actually there was no correlation between the change in cardiac index and the change of the vessel perfusion on a microcirculatory scale. And there was a very good correlation between lactate and microcirculation. Vasopressors, which we're using more and more as well. So in this study, they used noradrenaline to increase the blood pressure in an adult patient population from 65 to 75 to 85 mean arterial blood pressure. And as you can see, it did not really change the microvascular flow index. And also the vessel density all over did not change. But I would like to draw your attention to this picture, because what you see is initially there's no change, but this is a very interesting pattern. So this actually shows me that there's a group where there's no change whatsoever in the capillary density, but there is a group here that maybe has a reasonable functional capillary density to start with, and if you give vasopressors, it actually decreases, whilst other patients have a very poor microvascular density, microvascular vessel density perfusion, and they benefit from vasoconstrictors. So therefore, it is really important to look at your patients and try to assess which patient will benefit and which will not benefit from a certain treatment strategy. They've looked at vasodilators as well. So this was one of the first publications where orthogonal polarization spectral imaging was used. And they looked at the effect of nitroglycerin, and these were very exciting findings, because they found that in patients with septic shock, a vasodilator actually improved the microcirculation and also improved outcome. Nevertheless, a subsequent study more recently by Christian Boerma that was randomized, controlled and blinded could not find the same observation. So they did not find a difference between placebo and a vasodilator. So I've given you a bit of a flavor of what do we see in a microcirculation, and there are ways to influence it. And I think it's very nice to see that there's a general agreement that there's a really important role for the microcirculation. So already in 2008, in the Surviving Sepsis Campaign guidelines, there was attention drawn to the microcirculation and that we need to try to optimize the microcirculation and focus our treatment strategies in improving microcirculatory perfusion. So in conclusion, due to its non-invasive nature, monitoring of the microcirculation has a great potential, especially in the neonatal population where other monitoring strategies are limited. We've seen alterations in the microcirculation in critical illness, and those are observed in all age groups from very premature neonates up to adults across the whole population. Development of microcirculatory flow pattern of the buccal mucosa correlates with outcome in septic shock, and at present we're expanding that knowledge. Treatment strategies can have important implications on the microcirculation, and therefore we should consider those effects when we resuscitate our patients. Thank you very much for your attention.